Good morning, everybody. We'll be going with the next presentation with Professor Gopal Nath, sir. If there are any questions for the participants, please put in Q&A session. Sir will be answering. Few things we'll send you in mail also. Please join this very important presentation. The moderator also joined, D. Suresh Kumar, sir, Best of ID, co-founder, my mentor in ID. Thank you, sir. This session is titled as Fast Therapy, Bench to Bed. Moderator would be Dr. D. Suresh Kumar, sir, co-founder of Best of ID, senior consultant, ID physician at Apollo Hospitals. Good morning, sir.
Yeah, thank you, Dr. Gerard. Thanks for the wonderful opportunity. And I sincerely thank, because you have muted me just now, unmuted. Thanks for the wonderful opportunity. It's a pleasure to listen to Dr. Gopal Nath. Gopal Nath is a professor as well as Dean Research, Professor of Microbiology and Dean Research at Banaras Hindu University. And he's a pioneer in bacteriophages. He's one of the first persons to use bacteriophages therapy, not only in clinical trials, but also in a couple of patients, real patient scenario is used it. And his interest is not only the bacteriophages, apart from the bacteriophages, he has got interest in gastrointestinal infections and microbial functional genomics also. And right now he's president of SBRT. And my panelist, Dr. Rajesh Kesavan, myself and Dr. Rajesh were classmates from UG, and almost 30-35 years we are known to each other well. And right now he's a founder of Dr. RK Diabetic and Food Hospitals, RK Food Hospitals, and he is also a vice president of Diabetic Food Society of India. He has got extensive experiences in treating difficult skin and soft tissue infections with a lot of resistance antibiotics, and he do a lot of pioneering things in the diabetic food management infections. So, without further ado, I just ask the speaker, Dr. Gopal Nath sir, to start his presentation. And participants, please post your questions to the chat box so that sir can answer at the end of his presentations. Open to you, sir.
Okay, thank you, Dr. Suresh and Dr. Rajesh.
Yeah, thank you for the wonderful presentation, Dr. Gopal Nath.
Thank you
I
very
think
much.
we are muted, so you're not able to call right now immediately. I asked my co-panel, Dr. Rajesh Kesavan, to throw what is his experiences or what is his view on his bacteriophages therapy, because he did a lot of chronic non-healing wound ulcers and diabetic food ulcers, bad diabetic food ulcers. He is a pioneer and he used a lot of other methods like hyperbaric oxygen therapy and everything you do. So I'll ask Dr. Rajesh to throw some light. What do you think about bacteriophages in his practice, sir?
Yes, sir. So that was a very great presentation, sir. I think I usually we treat a lot of diabetic foot patients, and most of the cases that you had shown had foot wounds. I presume they could be diabetic foot wounds. And as my good friend Suresh knows, most of the patients, at least 30 to 40% of them, come with multi-drug resistant infections, and a few of them pan-resistant infections. And we are always in a fix as what antibiotic would help and how to manage these infections. Looks like this is a good way to treat them. A few questions, sir. I mean, how long? I mean, again, you said it is a customized phage therapy. How long does it take to customize? And the second thing you said is it takes about 21 days for the result to be seen. But again, in the case study that you had shown, the improvement started happening by about 4 to 5 days.
Yeah. So in case of septicemia, actually when the bacteria, actually, in this case, we could isolate the bacteria from the blood also, from the urine also, Klebsiella pneumoniae. So she was really into septicemia. So septicemia condition definitely improved within 3 days, 72 hours. But the infection at the implant site, it was probably in the biofilm form that took longer.
Okay. And how long does it take to customize and maybe start treatments? Huh?
Yeah. And then the story is that when we isolate the bacteria, it takes about 7 days, because these are the chronic infections. So it doesn't matter, because they have already is in waiting for 1 month, 2 months like this. So in 7 days, we usually get the bacteriophage preparation ready to use. And what is the ideal condition, that we are having the collections of all the centers, say 4 centers in the whole country, maybe many more centers. They are having the phage library every place against the escape organism. And then whenever
Okay.
bacteria is coming out, you are just testing like you are testing with the antibiotic discs. And then immediately next day you can supply the bacteriophage cocktail after testing. This is the ideal condition. And we hope that one day we'll achieve this goal.
Wonderful, sir. Wonderful. I think through Dr. Suresh, I think I'll be in touch with you. So maybe we
Sure,
should
sure.
also look at
Yeah,
trying
it's
to
my
manage.
pleasure. Yes, yes, yes.
Thanks a
Sir,
lot, sir.
last
Thank
year,
you.
last year I was in Taramani with the conference happening in Chennai that time there. Apart from your center, any other centers, for example, I know VIT is doing a lot of work, but any other center is providing bacteriophages apart from your centers to the clinical use?
Hello.
Hi.
Hello, can you hear me now?
Yeah, yeah.
Apart from
What
your
is your
center, apart from your center, any other centers in India
no,
providing
no, no,
bacteriophages to?
no, no, sir, no, sir. We are the only center who are using in clinical practice, and we are having because actually, what is the issue? I'm the in charge of one of the viral research and diagnostic laboratory, and then my all PhD students almost they have worked on each of the bacteria of the escape group of organism. One PhD on it on one bacteria. So this is why we were having, but the thing is that when the manpower is not there, then it will be difficult. And we are facing this problem. We have treated a lot of cases of the chronic prostatitis also. Dr. Pranav Jahari will be speaking on this because he himself was the patient, and initially he started thinking about this. And then only thing is that this needs the huge number of the manpower continuous, like manufacturing is a bit difficult, and then it's very easy to isolate, but the thing is that your preparation should be following the good manufacturing practice. There should not be any endotoxin or minimal level of endotoxin. That is important. The other is that the dosing in the critical conditions, and usually it is suggested that you must start with the smallest dose, gradually increase, and keep an eye on the different parameters of the like blood pressures and the oxygen demand and all these things. So, and then you can manage it.
During the last year conference in Chennai, the Vellore Institute of Technology also saying they are doing a lot of research, but I have not came across any clinical usage from the Vellore Institute of Technology.
Yeah,
That's what I'm
actually,
asking.
they have to collaborate with the hospitals, and they have to collaborate with the clinicians. Then only they can do. And I think one day they will be doing this.
Some of the questions posted in the group chat box I had asked, sir. They want to see in what formulation is available. Can it show some of the vials or some of the formulations? Is it possible there? That's what some of the persons is asking there.
What we are doing is that we are preparing the liquid formulations and putting in the sterile vials. Another thing we are doing is the lyophilization. So, like in Klebsiella pneumoniae case, my PhD scholar made a huge number of the lyophilized preparations, and still we are having that one. But the only thing is that we have picked up 3 bacteriophages which are having broad spectrum activity. And there are many scopes, there are many phages which are broad spectrum across the bacterial species also they work. So by the way, if you are getting some of the bacteriophages which are acting across the bacterial species and that also against the escape organisms. So maybe we are having the cocktail for using to be used in the critical condition without testing initially on empirical ground. So that is expected, but again, it needs a lot of laboratory work.
Yes. Next question is why some bacteria are not responding, sir?
Where? Actually, you know that the during therapy, why we are using the cocktail so that we are taking the any mutant which is coming out and it becomes resistant to the single monotherapy that takes care by the taken care by the other phages. This is why as we treat the mycobacterial infection, the multiple drug therapy is given. The same we are doing here. And by chance, if some of the phages bacteria are getting mutant, so then again you have to isolate and we have to isolate the new phages and you have to treat. That's why we should have the battery of the phages with us. So one cocktail is not working, we may shift to the another cocktail. That can be done. The other question people ask is that you are giving for such a long time Bhas therapy and they are protein nature, why the antibodies are not rising? They can, the patient may have the neutralizing antibody. So that is not usually occurring. And even if it occurs, it takes 21 days. And that's why we should have the antigenically different bacteriophages, lytic phages against the same bacteria in our store so that we can shift to that one. That is the answer to this. Why bacteriophages are not inducing a very high immune response? The reason that they are basically the commensal flora of our gut and our body. So, if they are just colonizing in the initial years of our life, they are not inducing immune response. That's why our body is tolerating very well and they are not inducing the immune response. So this is the answer to this. So this is a very good point about the bacteriophages.
One more question is, what is the cost of the therapy? I know that this is compassionate ground only we are using it, right? They're asking about cost of the therapy. Suppose somebody wants to use it, what is the cost of the therapy?
Cost is very minimal. Only thing is that uh, it needs a huge number of the manpower because it takes 7 days. Suppose one scholar is just working on one patient, so he must be putting 7 days. Means you can see at least 20 hours for this, and for purification the process keeps on going. Otherwise, just collecting the water from sewer or from river and then getting the plaques, purifying it, the material is not expensive. You don't need to have the very expensive machines also because there is no need of the ultracentrifuge. You can purify the endotoxin with the help of the membrane dialysis only with the 20 nanometer pore size. That can be done anywhere in the refrigerator. It's not a huge cost on this.
Another question is, any center providing training to the doctors?
Please repeat.
Any center providing training? Or any
Training.
center interested in research?
Yeah. The SBRT actually is trying to hold many workshops and other things. I myself organized 2 workshops, and the next conference will be happening at BHU Varanasi itself, and we'll be having 3 days workshop before the conference. So that will be happening maybe in November 2025. So I shall be doing, and earlier also we have done it. If somebody is interested, they can visit our lab. They can stay with us at least 1 week. Then they can learn the basics of the bacteriophage isolation.
And one more question is there any difference between MDR gram negative and MDR gram positive response?
Oh, yeah. The MDR gram positive, we don't talk about the MDR actually. We are not concerned with what is the status of the antimicrobial resistance because the bacteriophages don't bother about this. The only thing is that MDR are gram-positive bacteria like Enterococcus, Staph aureus, their plaques are quite small usually. And for that reason, when you are isolating the phages or you are doing the soft agar overlay, the concentration of the soft agar should be quite low. It may be 0.4% only. Otherwise, the plaques may not be visible. While in case of gram-negative bacteria, the plaques are usually very huge, big one.
The other question is, what will be the effect on the normal flora?
As the previous worker Gerard has spoke about this, they are very specific. That is the issue. That is why the phage therapy failed in the initial years of during 1920 to 1940 because they were not knowing that this is so specific. So it will just these are like the smart bomb. They will go and kill their targets only, nothing to do with other bacteria. Here, I would like to emphasize one more thing that the phages can kill the intracellular bacteria also because they are nanoparticles. They enter the cells, and if the host is there inside the cell, they are going and getting replicated, and they can kill the infecting bacteria there also. We have done this, and we have published also in case of Salmonella typhi.
And then one more question is, you said you have treated patients with septicemia and pneumonia. In which form you have taken the phage cocktail to treat pneumonia, like in a liquid or lyophilized form?
Now this is in a liquid form. Usually we send through the courier, and then they are using in the nebulizer, means they are in the droplet form to the patients. So this work is being done by Kalyan Chakravarti at Guntur. So he has taken 3 cases there, and he is in active collaboration with us.
Lot of thank you messages, and people are asking about sharing the workshop details. Can we say such phage therapy for MDR and XDR TB, is it possible?
Yes, that is my dream. Actually, I'm retiring in coming 1.5 years, so I could not do it. But the answer to this is a bit laborious work, time taking. It is possible. And what we have done till date is that you are taking the rapid growing mycobacteria, which are just giving the visible colonies between 48 hours to 72 hours. And maybe you are having the 200, 300 different phages against these rapid growers. and you are testing these phages to the on the mycobacteria later on, and because the mycobacteria must be having some sharing receptors, so some of the phages, if you are they are working on the, because you cannot isolate, it is very difficult to isolate the phages against M. tuberculosis, the reason being that their generation time is too long. So phages may not be there, but this can be done. And if you get the sensitive phages against the mycobacteria tuberculosis, which you have isolated on the rapid growers, that may be, and one day it will be possible, I think, if somebody is doing, and some people are trying also. Dr. Urmi is trying at New Delhi to get a project on this one. And we are having the library of the phages against the rapid growers in my lab.
One provocative question, sir. Can phages replaces antibiotics?
Yeah, please repeat.
Can phage can replace antibiotic?
No,
in the
there is
future?
no need. There is no need. They will go hand in hand, actually. You see, when you use the bacteriophages in animals, in poultry, and in a fishery, and in human being, so if the reduction of the antibiotic use comes down to 50%, naturally the antibiotics will again be effective. Another thing I told you that there is phage antibiotic synergy in a great way. In a great way, you will not believe that this magic is there, and you can treat with the single or two doses of bacteriophages. And when you are giving the antibiotics which are not effective, even then they become effective. So we have published 3 papers on this issue, and we have found the result also.
Okay.
So both will remain there.
Sir,
Yeah.
then one more question is, have you used the phages for the fungi treatment of fungal infections?
Yes, this is another one like Mycobacterium tuberculosis. And you see the some of our collaborator is trying to find out the phages against the Candida. And again, the story goes in the same way. It is a bit difficult, but you know the viruses for all living cells are there. So it is not possible that the Candida or fungi are not having the phages for them. So it is there. It is a matter that we are working on them. We'll find one day.
So if no more further questions, we are also closing to the time now. I sincerely thank the speaker giving a great descriptions of the phages and sharing his experiences as well as his publications and answering all the questions posted in the chat box. I also thank my panel, Dr. Rajesh Kesan, for considering this one. We definitely will explore the collaborations with your center because as my panelists have been told, Dr. Rajesh, we are dealing with a lot of difficult diabetic foot infections with the pan-drug resistance organisms. But difficult for us. But we'll try to collaborate with their centers and do some good research for the benefit of the people. And I sincerely thank the organizers and particularly Dr. Gerard Rakesh for inviting us and providing a wonderful opportunity. And I also thank the participants for posting a lot of questions to the speaker. I think we are on time, and I close the sessions with the permissions. Thank you, sir. Thank you.
Thank you very much. I'm really grateful to the IMM chapter Pondicherry chapter basically. So they have organized this one, and it is great opportunity for all of us. Thank you very much. Thanks to the organizers.
Thank you, Gopal sir. Thank you, Suresh sir and Rajesh sir. Busy schedule Sunday. Traveling, both are traveling, sir, but they have come for us, sir. Thank you, sir. Thank you so much, sir.
Okay, welcome.